Welcome to the Hospital Medicine Unplugged podcast. Today we're tackling a really high-yield topic, something we see almost daily on the wards, Euthyroid Sick Syndrome.
Or Non-Thyroidal Illness Syndrome, NTIS, same thing.
Right, NTIS. It pops up constantly in the labs of our sickest patients, and frankly, it can be a real headache, diagnostically speaking.
It really can. It's a fascinating bit of metabolic adaptation, but you absolutely need clarity on what it is, and maybe more importantly, what it isn't.
Exactly. So that's our mission for this deep dive. Get crystal clear on the definition, understand the why behind it, the physiology, and crucially, figure out how to reliably distinguish it from true thyroid problems.
Because the last thing you want to do is start thyroid hormone on someone who doesn't need it. That's the core challenge here, exercising that clinical restraint.
Okay, so let's start with that precise definition. We're talking about abnormal thyroid function tests, right?
Correct. Abnormal thyroid function tests, TFTs, but, and this is the key, only in the setting of some other significant acute or chronic systemic illness.
And the thyroid gland itself is okay.
That's the fundamental exclusion. There's no intrinsic pathology in the thyroid gland itself. It's not Hashimoto's, it's not Graves'. The gland is structurally sound. The body's just reacting to systemic stress.
Got it. So what's the typical lab pattern we're looking for?
Well, the earliest and most consistent finding is a low serum T3, the triiodothyronine. That active hormone level drops pretty quick.
Okay, low T3 first. What about T4 and TSH?
The T4, thyroxine, can be normal, especially early on, or it might drift low depending on how sick the patient is, binding protein changes, that sort of thing.
And the TSH, this is where it gets tricky, right? Because you'd expect it to go up if T3 and T4 are low.
Exactly. But in ESS, the TSH is typically normal, or it can even be low. It doesn't rise appropriately in response to the low peripheral hormones. That's a central piece of the puzzle.
That disconnect from the normal negative feedback.
Precisely.
And you mentioned a key differentiator earlier, reverse T3.
Yes, RT3. This is really helpful, though not always routinely available depending on the lab. In ESS, reverse T3 is typically elevated.
Why is that?
It's a direct result of how the body handles T4 under stress. Instead of converting T4 to the active T3, peripheral enzymes shunt it towards making the inactive reverse T3. So high RT3 strongly points towards NTIS rather than, say, central hypothyroidism where you'd expect it to be low or normal.
Okay, so low T3, normal T4, normal TSH, and often a high reverse T3. That's the biochemical signature.
That's the classic pattern.
Now, why does this matter so much clinically? It's just a lab finding, isn't it?
Well, yes and no. It is a lab finding, but it's not just an innocent bystander. The degree of these thyroid hormone changes, especially the drop in T3, acts like a metabolic barometer.
Meaning it reflects how sick the patient is.
Exactly. It correlates directly with the severity of the underlying illness. Multiple studies, really solid data, show that lower T3 and free T3 levels are independent predictors of bad outcomes.
Like mortality.
Yes. Increased mortality, 28-day, 90-day mortality, longer ICU stays, more ventilator days, greater resource utilization in general for critically ill patients. It's a significant prognostic marker.
Wow, okay. So it's not just an artifact. It signals real metabolic trouble.
Correct. And that brings us back to the core clinical challenge. Recognizing that this is, at least initially, usually an adaptive response by the body.
Adaptive how? Like trying to save energy.
Precisely. The body is trying to dial down its metabolic rate, reduce energy expenditure, conserve resources during a major physiological crisis like sepsis or trauma. Lowering active T3 helps achieve that.
But the danger is mistaking this adaptive response for true primary hypothyroidism.
That's the pitfall. If you see low T3, low T4, and maybe a lowish TSH, you might think, hypothyroidism, and reach for the levothyroxine.
Which, based on the evidence, is generally the wrong move in ESS.
Definitely the wrong move. It doesn't help, and as we'll discuss, it could potentially cause harm. So understanding the why, the pathophysiology, is key to avoiding that mistake.
All right, let's dive into that pathophysiology. Why does the body orchestrate this specific shutdown? Is it always adaptive, or can it become harmful itself?
That's the million-dollar question, really. It seems to have this dual nature.
Okay.
Initially, throttling down metabolism makes sense. Think about severe sepsis, major burns, bad heart failure. The body is under immense stress, oxidative stress, high energy demand.
So reducing T3 lowers the basal metabolic rate.
Exactly. It conserves ATP, reduces protein breakdown. It's like metabolic hibernation, trying to weather the storm by slowing down non-essential functions.
Makes sense, but when does that adaptation potentially cross the line?
The concern arises in prolonged or extremely severe critical illness. If the body stays in this low T3 state for too long, does that adaptive response become maladaptive?
Could it lead to actual tissue hypothyroidism in vital organs?
That's the theory. Maybe the heart muscle or skeletal muscle or the immune system itself starts to suffer from a lack of sufficient T3 signaling, even if the initial shutdown was protective. This is still debated, but it's the rationale behind some of the treatment controversies.
Okay, so let's get into the mechanisms. How does the body actually lower the T3? You mentioned peripheral enzymes.
Yes, the deiodinases. These enzymes are absolutely central to the whole process. They control how T4 is activated or inactivated in the peripheral tissues.
And their activity changes dramatically in sickness.
Completely flips. There are 3 main types, but for ESS, we focus mainly on type 1 and type 3.
Okay, type 1.
Type 1 deiodinase is normally busy converting T4 into the active T3. It's found mostly in the liver, kidneys, thyroid gland itself.
And in acute illness,
its activity plummets. There's a significant reduction in type 1 activity, probably mediated by cytokines and nutrient deprivation. So less T4 gets converted to T3. Step 1 of the T3 drop.
okay, less production. What about type 3?
Type 3 deiodinase does the opposite. It inactivates thyroid hormones. It converts T4 into that inactive reverse T3 we talked about, and it also breaks down active T3 into T2.
And where is type 3 found?
It's normally in the brain, skin, placenta, but crucially, its expression gets massively upregulated in sick tissues, areas of inflammation, hypoxia, ischemia.
Ah, so in sepsis or injury, type 3 activity increases.
Dramatically. So now you have a double whammy. Type 1 is down, so less T3 is being made from T4. Type 3 is up, so more T4 is being shunted to inactive RT3, and any T3 that is around is getting inactivated faster.
Which perfectly explains the lab pattern. Low T3 and high RT3.
Exactly. It's the direct biochemical consequence of this enzymatic shift. That high RT3 is like the smoke signal of type 3 working overtime.
And you mentioned type 3 being upregulated in hypoxic tissues. Does that mean the low T3 we measure in the blood might underestimate how low it is in specific organs?
That's a really important concept, the idea of local tissue hypothyroidism. The systemically measured T3 might be low, but in an inflamed lung or an ischemic kidney, the T3 level could be even lower because type 3 is so active right there.
Which feeds back into that maladaptive theory. Maybe certain organs are truly T3 starved, even if the systemic picture looks borderline.
Precisely. But the control isn't just peripheral with the deiodinases. The brain gets involved too, especially when things get really bad or drag on.
The central HPT axis suppression.
Right, the hypothalamic pituitary thyroid axis. In severe or prolonged illness, you start to see central suppression layered on top of the peripheral changes.
How does that manifest?
It seems to start at the top, in the hypothalamus.
Yeah.
There's evidence for decreased production or release of TRH, thyrotropin-releasing hormone.
Less TRH signal to the pituitary.
Correct. And the pituitary itself becomes less sensitive to TRH, and the way it releases TSH changes. The normal pulsatile secretion gets blunted.
So the net effect is lower TSH production and release.
Yes. This leads to that normal or, frankly, low TSH level we see. Even when peripheral T3 and T4 might be falling, the pituitary just isn't responding as it should. This is particularly prominent in very severe, prolonged critical illness.
Okay, so we have peripheral shunting via deiodinases and central suppression of the HPT axis. What's driving all this? What's the conductor of this whole endocrine downshift?
Inflammation. It really boils down to the inflammatory mediators released during severe illness.
Cytokines?
Absolutely. Things like interleukin-1, IL-1, interleukin-6, IL-6, tumor necrosis factor alpha, TNF-α. These are the main culprits.
How do they do it?
They work both centrally and peripherally. Centrally, they directly suppress TRH release from the hypothalamus and can blunt the pituitary's TSH response. Peripherally, they are key signals that alter deiodinase expression. They tell the cells to make less type 1 and more type 3 enzyme.
So the degree of inflammation directly dictates the degree of thyroid suppression.
Largely, yes. It's a coordinated shutdown mediated by the intensity of the inflammatory storm.
And what about stress hormones, like cortisol?
Good point. Elevated glucocorticoids, whether from the body's own stress response or from administered steroids like hydrocortisone or prednisone, also play a role.
Oh.
They primarily act centrally to suppress TSH secretion from the pituitary. They can inhibit the TSH gene itself. This adds another layer of complexity, especially when interpreting labs in a patient on stress-dose steroids. Their TSH might be low, partly due to the steroids, not just the illness.
Okay, that paints a pretty comprehensive picture of the how. Now let's talk about the when and where. Which specific illnesses are notorious for triggering ESS?
Oh, it's a long list. Pretty much any severe systemic illness can do it. The classic triggers you think of are things like severe sepsis, septic shock.
Right, the really sick ICU patients.
Exactly. Major surgery, especially complex procedures like cardiac surgery or big abdominal operations, extensive trauma, severe burns. These are all massive physiological stresses.
But we see it outside the ICU too, right? On the general medicine floors.
Absolutely. Decompensated organ failure is a huge driver. Bad heart failure exacerbations, acute kidney injury, end-stage liver disease.
Makes sense.
Also, widespread malignancy, particularly with cachexia, and just prolonged critical illness from any cause. If someone's been stuck in the hospital unwell for weeks, their thyroid labs are almost certainly going to reflect ESS.
So basically, if your patient is sick enough to be in the hospital, especially if they're critically ill, ESS is likely on the table.
Very likely.
Are there particular factors that increase the risk or make the ESS more severe?
Yes, several things. Older age is definitely an independent risk factor. The changes tend to be more pronounced in elderly patients.
Malnutrition, too.
Yes, malnutrition or a significant catabolic state is a big one. Poor nutrition itself can inhibit type 1 deiodinase, worsening the T3 drop. Low albumin often correlates with the severity of ESS.
And then there are medications, which we have to be mindful of.
Always. We mentioned glucocorticoids suppressing TSH. Dopamine infusions, often used for pressor support in the past, also suppress TSH centrally.
What about dobutamine?
High doses of dobutamine can also have some TSH suppressive effects, though maybe less potent than dopamine.
And the big one you often see on cardiology or medicine services, amiodarone.
Amiodarone. It's a classic confounder. It messes with thyroid function in multiple ways.
How so?
Well, structurally, it contains a lot of iodine and resembles T4, so it can interfere with hormone binding and metabolism. But more directly relevant to ESS, amiodarone is a potent inhibitor of type 1 deiodinase.
So it directly blocks the T4 to T3 conversion.
Exactly. If you start someone on amiodarone, especially an IV load, you will almost certainly see their T3 level drop, inducing or worsening an ESS pattern. It can also sometimes cause true hypo or hyperthyroidism later, but the acute effect is usually ESS-like.
It's interesting how closely ESS severity tracks with things like ICU scoring systems, like Apache 2 or SOFA scores.
It is, but it makes perfect sense, right?
Yeah.
Those scores are designed to quantify the overall burden of critical illness, the degree of organ dysfunction, inflammation.
So higher scores mean more inflammation.
Which means more IL-6, more TNF-α, more cytokine drive.
Which means more type 3 deiodinase activity and more central suppression.
Leading to lower T3, lower T4, lower TSH. It all fits together. ESS is essentially a biochemical readout of how stressed the body is.
And other markers correlate too, like low albumin, high BNP.
Yes, those often track along with ESS severity. Low albumin reflects that malnutrition and catabolism. High BNP indicates severe cardiac strain, another major stressor. Even things like thrombocytopenia, suggesting widespread endothelial damage and sepsis, correlate with more pronounced ESS. It's all part of the picture of systemic illness severity.
Okay, so we have the causes, the risk factors. What about the clinical presentation? How does a patient with ESS look?
This is probably the single most important clinical point.
Yep.
Patients with ESS generally do not have specific signs or symptoms of thyroid dysfunction itself.
Meaning they don't look hypothyroid?
Yeah.
No puffy face, slow reflexes, cold intolerance.
Correct. They might be hypotensive, altered, tachypneic, tachycardic, maybe even hypothermic if they have severe sepsis. But those signs are entirely attributable to their underlying primary illness. The sepsis, the heart failure, the trauma.
So there's nothing on the physical exam that shouts Euthyroid Sick Syndrome.
They're nothing specific. The diagnosis is made by recognizing the characteristic lab pattern in the context of a severe systemic illness and, crucially, by excluding true thyroid disease. It's an incidental lab finding in a sick patient.
And you emphasized earlier that the low T3 is the most sensitive part of that lab picture.
It really is. It's the earliest and most consistent change. And as we discussed, that low T3 level carries significant prognostic weight regarding mortality risk, both in the ICU and even on general hospital wards. If the T3 is low, that patient is physiologically quite sick.
Okay, so since the clinical exam is silent for ESS itself, making the diagnosis and, more importantly, distinguishing it from the dangerous mimics hinges entirely on interpreting the lab patterns correctly, often over time.
Precisely. This is where careful lab interpretation is critical to avoid misdiagnosis.
Right.
We need to differentiate ESS from primary hypothyroidism, central hypothyroidism, and the real emergency, myxedema coma.
Let's walk through how the lab pattern typically evolves during the course of an illness and recovery. You mentioned phases earlier.
Right. We can think about it in roughly 3 phases. First is the acute phase. This is what we most commonly encounter initially.
What defines that?
Low T3 is the key. T4 might still be normal or just starting to dip slightly. TSH is usually normal or maybe slightly low. And if you were to check it, reverse T3 would be high. This reflects that initial peripheral shunting via deiodinases.
And this can be transient.
Often, yes. If the underlying illness is treated effectively and resolves quickly, these labs might normalize relatively fast.
What if the illness is really severe or drags on?
Then you can progress to the severe or prolonged illness phase. Here, the central suppression really kicks in on top of the peripheral changes.
So what happens to the labs then?
The T3 stays low, but now the T4 level also drops significantly. And importantly, the TSH becomes frankly low, not just low normal. This pattern, low T3, low T4, and low TSH, signifies a much more profound and sustained systemic insult that has shut down the entire HPT axis.
And this pattern carries a worse prognosis.
Definitely. This pattern is associated with higher mortality than just isolated low T3.
Okay, and then hopefully the patient starts to get better. What happens during the recovery phase?
The recovery phase actually provides a very useful diagnostic clue. As the underlying illness resolves and the body recovers, the thyroid tests start to normalize, but they do it in a specific sequence.
How so?
We often see a transient rise in the TSH level and might even go slightly above the upper limit of the normal range for a period.
A TSH surge. Why does that happen?
It's the pituitary waking up, the central suppression lifts, and the pituitary senses the low peripheral T4 and T3 levels and tries to stimulate the thyroid gland to ramp up production again and replenish stores.
Ah, so that temporary TSH elevation is actually a good sign.
It's an excellent sign. It confirms that the HPT axis was just temporarily suppressed by the illness and is now recovering its function. It helps definitively distinguish ESS from true, permanent primary hypothyroidism, where the TSH would stay persistently high.
That's a really key point for follow-up testing. Okay, let's pivot to those critical differential diagnoses. The things we absolutely cannot afford to miss. Start with primary hypothyroidism.
Primary hypothyroidism is usually the most straightforward to distinguish based on the TSH. The thyroid gland itself is failing.
So labs show
Low free T4, but the pituitary is trying desperately to stimulate the failing gland, so the TSH is persistently and significantly elevated, usually well above the normal range, often greater than 20 or 25 microunits per milliliter, sometimes much higher, even into the hundreds.
So a TSH of, say, 8 or 10 during recovery from ESS is very different from a TSH of 50 in primary disease.
Completely different context and magnitude. You wouldn't mistake that transient recovery surge for established primary hyperthyroidism if you see the whole pattern. Antibody testing, like anti-PPO antibodies for Hashimoto's, can also help confirm primary disease if needed.
Okay. Now the trickier one, central hypothyroidism.
Yes, this one can look more similar to severe ESS on paper because both can have low T4 and low TSH. But the underlying cause is totally different. It's a problem with the pituitary or hypothalamus itself.
So what's the key lab differentiator?
In central hypothyroidism, you have a low free T4, but the TSH is either low or perhaps more treacherously, it's inappropriately normal. It's not 0, but it hasn't risen at all despite the low T4. The pituitary just isn't responding.
When should we have a high index of suspicion for this?
You have to think about it in patients with known pituitary tumors, a history of pituitary surgery or radiation, significant head trauma, postpartum pituitary necrosis, Sheehan syndrome, or if the patient has other signs of pituitary hormone deficiencies like secondary adrenal insufficiency.
And this brings up a massive safety issue, right? If you suspect central hypothyroidism, you can't just give levothyroxine straight away.
Absolutely critical point. You must not start thyroid hormone replacement until you have assessed the adrenal axis.
Why is that?
Because pituitary failure often involves multiple hormone lines, panhypopituitarism. If the patient has concurrent undiagnosed secondary adrenal insufficiency, low ACTH leading to low cortisol, and you give them thyroid hormone first.
T4 increases metabolic rate.
Exactly. It increases the metabolic clearance of cortisol. If the patient can't mount an adequate cortisol response because their adrenal axis is down, giving T4 can precipitate a life-threatening adrenal crisis.
Wow. So if central hypothyroidism is on the differential, check cortisol levels first.
Yes, a random cortisol, or ideally an AM cortisol, or even perform a cosyntropin stimulation test if suspicion is high, before initiating levothyroxine. Always rule out adrenal insufficiency first and suspected central hypothyroidism.
Okay, vital point.
Yeah.
And the last differential, the true emergency, myxedema coma.
Myxedema coma is the extreme manifestation of severe, untreated, usually primary hypothyroidism. It's a clinical diagnosis primarily, but the labs support it.
How does the patient look?
They're profoundly ill, altered mental status, often obtunded or comatose, severe hypothermia, marked bradycardia, hypotension, hypoventilation, multi-organ dysfunction. It's a state of near-total metabolic collapse.
And the labs?
Typically show a markedly elevated TSH, often extremely high, with a very low free T4. But clinically, you often have to act before all the labs are back based on the extreme presentation. Treatment involves immediate IV thyroid hormone, often both T4 and T3, and high-dose stress steroids because you can't rule out concurrent adrenal issues initially.
Okay, so a very different catastrophic clinical picture compared to the typical ESS patient.
Worlds apart clinically.
So kind of synthesizing these diagnostic tools, reverse T3 seems quite helpful if you can get it to support ESS.
It is. An elevated RT3 is strong biochemical evidence for that peripheral shunting mechanism characteristic of ESS. It helps differentiate the low T3 of ESS from the low T3 you'd see in early primary hypothyroidism, where TSH would be rising, or pure central hypothyroidism, where RT3 might be low or normal alongside low T4.
And always keeping pituitary and adrenal function in mind if TSH and T4 are both low.
Non-negotiable. Clinical context, looking for other pituitary deficits, and checking cortisol if central disease is suspected.
This detailed lab detective work naturally leads us to management. What's the guiding principle here? We've hinted at it, but let's be explicit. What do the major guidelines, like from the American Thyroid Association, ATA, say?
The ATA guidelines, and generally all major endocrine society recommendations, are very clear and consistent on this. The primary management of Euthyroid Sick Syndrome is not thyroid hormone replacement.
So what is the management?
It's supportive care and aggressive, targeted treatment of the underlying systemic illness that's causing the ESS in the first place. Treat the sepsis, manage the heart failure, optimize nutrition, address the trauma, fix the primary problem.
And the guidelines explicitly recommend against routine T4 or T3 therapy.
Explicitly and strongly not recommended. That is the absolute standard of care for ESS inanitis. It requires clinical discipline to see those low numbers and resist the urge to normalize them with hormone therapy.
And this isn't just expert opinion, right? It's based on solid evidence.
Absolutely. This conservative approach is built on decades of research, including numerous randomized controlled trials, RCTs, and large meta-analyses.
What did those studies show?
They consistently fail to demonstrate any significant benefit from giving T4 or T3 therapy to unselected critically ill patients with ESS. No improvement in survival, no reduction in ventilator days, no better major clinical outcomes. The hormones just didn't help overall.
And more concerning, was there evidence of harm?
Yes, some studies raised red flags about potential harm. For instance, certain analyses suggested that higher doses of thyroid hormone, particularly in specific subgroups like patients with acute renal failure, might actually be associated with increased mortality.
Increased mortality. Why would that be?
Well, remember, T3 drives metabolism. Giving exogenous T3 or T4, which gets converted to T3, increases oxygen consumption and metabolic demand in tissues that are already stressed and potentially borderline ischemic. You might be pushing them over the edge, especially in organs like the heart or kidneys.
That makes sense. So forcing the metabolism up when the body's trying to shut it down might be counterproductive or even dangerous.
That's the physiological argument against routine replacement, and the clinical trial data largely supports it.
So are there any exceptions? When would we actually treat with thyroid hormone in this setting?
Only when you have definitively diagnosed true underlying thyroid disease. If your workup confirms primary hypothyroidism, high TSH, low T4, or central hypothyroidism, low T4, inappropriately normal low TSH, after ruling out adrenal insufficiency, then yes, replacement therapy is indicated for that condition irrespective of the concurrent acute illness.
But not for the ESS itself.
Correct. You're treating the pre-existing or newly diagnosed thyroid gland failure or HPT axis failure, not the adaptive changes of ESS.
Now, you mentioned controversies earlier. What about those niche areas, like in cardiac surgery, where T3 is sometimes discussed?
Right, this does come up particularly in the context of post-cardiac surgery, patients who develop severe low cardiac output syndrome, sometimes called stunned myocardium.
What's the rationale there?
The heart muscle is very sensitive to T3 and needs T3 for optimal contractility. The theory is that in some post-op patients, profound acute drops in T3 might contribute significantly to myocardial dysfunction. So maybe replacing T3 could help cardiac performance.
And what does the evidence show for that specific scenario?
It's very limited and quite controversial. Some small, older studies suggested that short-term T3 infusions might transiently improve hemodynamic parameters like cardiac index or wedge pressure in these specific patients.
But did it improve actual outcomes, like survival?
That's the critical issue, no. Larger trials and systematic reviews have not shown consistent improvements in mortality, length of stay, or major adverse cardiac events. While hemodynamics might briefly look better on paper, it hasn't translated to meaningful clinical benefit.
So the consensus remains against it, even there?
Yes. The broad consensus, including ATA guidelines, remains against routine use even in post-cardiac surgery. It's considered experimental, maybe justifiable in very specific refractory low-output cases under expert guidance, like a cardiac intensivist or endocrinologist, but it's definitely not standard practice and carries risks. Extreme caution is needed.
Okay. That clarifies that niche area. Let's switch gears to practical testing strategy. Given how common abnormal labs are in sick patients, when should we actually order TFTs and when should we recheck them? We don't want to chase insignificant lab values.
That's a key point for resource stewardship and avoiding diagnostic confusion. We should actively avoid routine reflexive screening of thyroid function in acutely ill patients just because they're sick, unless there's a specific, strong reason to suspect underlying primary thyroid disease independent of the acute illness. For example, if the patient has a known history of thyroid surgery or radiation, a visible goiter, or classic signs of severe hypo or hyperthyroidism that really don't fit with their primary acute diagnosis.
Because if you test everyone who's admitted to the ICU,
you're almost guaranteed to find a low T3, maybe other abnormalities, and then you've opened a diagnostic Pandora's box that often leads nowhere helpful and might prompt inappropriate action.
Okay, so avoid routine screening. But what if you do find ESS labs, either incidentally or because testing was indicated? When do you recheck?
The general recommendation is to defer repeat testing until the patient has substantially recovered from their acute illness.
How long after?
Often weeks to months later, maybe 1 to 3 months after discharge or significant clinical stabilization. This gives the HPT axis time to recover fully and for the labs to normalize spontaneously, as they usually do. It also allows you to potentially catch that transient TSH rise during recovery, which is diagnostically helpful.
But what if the initial labs were really suggestive of true primary hypothyroidism, like a very high TSH from the start?
Good clarification. If the initial TSH is markedly elevated, say over 15 or 20, and the free T4 is low, that strongly suggests underlying primary hypothyroidism. In that case, you wouldn't wait months. You'd likely confirm with repeat testing sooner, maybe check antibodies and initiate therapy if clinically indicated, even during the acute illness.
So the deferral strategy is mainly for the typical ESS pattern with normal or low TSH.
Exactly. For the vast majority of cases presenting with the classic low T3 plus low T4 and normal TSH pattern, waiting until after recovery is the standard guideline adherent approach.
Makes sense. Let's talk about specific patient populations where ESS nuances are particularly important, starting with the critically ill ICU population.
Right. As I said, ESS is almost universal in severe critical illness. The key point in the ICU is its powerful prognostic significance.
We touched on this. Lower T3 predicts worse outcomes.
Yes, and the pattern matters. The risk associated with ESS is significantly higher when you have the combination of low free T3 and either low free T4 or low TSH compared to just isolated low T3.
Indicating that more profound combined peripheral and central shutdown.
Correct. That pattern signals an overwhelming systemic insult and predicts higher 28-day and 90-day mortality, longer ventilator dependence, and generally a poorer prognosis.
And we need to remember those ICU-specific medication effects too.
Absolutely. Dopamine, high-dose dobutamine, concurrent steroids all can suppress TSH and confound the interpretation. You always need to consider the full clinical context and medication list in the ICU.
Okay, shifting from the ICU to post-surgical patients and maybe the elderly or frail population.
Post-surgery ESS is also extremely common. It's driven by the surgical stress itself, the inflammatory response, anesthesia effects, often calorie restriction pre and post-op, maybe perioperative steroids.
Is it usually transient after surgery?
In otherwise relatively healthy patients undergoing uncomplicated surgery, yes, it's typically transient and resolves fairly quickly as they recover.
But what about in elderly or frail patients undergoing surgery or just hospitalized for other reasons?
In this population, ESS takes on perhaps even greater significance. Frailty itself is often associated with baseline alterations in thyroid hormone metabolism. When you add an acute illness or surgical stress on top of that,
The ESS is more pronounced or concerning.
it's often more pronounced, and it correlates strongly with adverse outcomes in this group: higher post-op mortality, longer hospital stays, functional decline, need for rehab, and it often tracks with markers of poor nutritional status and sarcopenia.
And is the risk of treating ESS potentially higher in the frail elderly?
Definitely. This is where the adaptive nature of ESS might be most relevant. Trying to correct the low T3 in a frail elderly patient with underlying, perhaps undiagnosed cardiac issues could be particularly dangerous.
By increasing metabolic demand.
Precisely. Giving T4 or T3 could increase myocardial oxygen demand, potentially tipping them into ischemia, arrhythmia, or worsening heart failure. Overtreatment with thyroid hormone in the frail elderly with ESS must be avoided at all costs. The principle of treating the underlying condition and providing supportive care is paramount here.
So across all these settings, ICU, post-op, elderly, the common thread is that ESS is a powerful marker of illness severity and poor prognosis.
That's the fundamental takeaway. It tells you the patient is sick, and the sicker they are, generally the lower their T3 will be.
But, and this is the crucial point we keep coming back to, the overwhelming evidence tells us that fixing the number doesn't fix the patient.
Correct. Treating the ESS itself with thyroid hormone does not improve outcomes based on current data and carries potential risks. The focus has to remain squarely on diagnosing and managing the underlying cause of the systemic illness. That's what drives the ESS, and resolving that illness is what allows the thyroid labs to normalize.
Okay, let's try to synthesize the key messages. We've defined ESNTSS as abnormal TFTs, typically low T3, variable T4 TSH, high RT3, due to systemic illness, not thyroid gland failure.
We've explored the pathophysiology, the switch in deiodinase activity driven by cytokines and stress, leading to peripheral shunting, sometimes coupled with central HPT axis suppression in severe cases.
We've detailed the lab patterns and how they evolve, emphasizing the TSH rebound in recovery. And critically, we've contrasted ESS with primary hypothyroidism, central hypothyroidism, and the associated adrenal risk, and myxedema coma.
And we've landed on the evidence-based management principle strongly advocated by the ATA. Treat the underlying illness, provide supportive care, and explicitly do not routinely use thyroid hormone replacement for ESS.
It really requires clinical discipline to see those abnormal labs, especially in a very sick patient, and consciously choose not to intervene with hormones.
It does, but that restraint is entirely data-driven and patient-centered. We trust that the body's endocrine response, while reflecting severity, is generally adaptive, or at least not the primary target for intervention, unless proven otherwise by diagnosing true thyroid disease.
So this brings us to our final provocative thought for the listeners. We've established ESS is a strong prognostic marker, but treating it doesn't help. Yet that strong correlation nags at you. Could there be a point where it does become maladaptive?
Right. Thinking about that patient with chronic critical illness, maybe stuck on the ventilator for weeks, failing to wean, persistently catabolic, is the ongoing low T3 state in that specific context actually contributing to muscle weakness, poor recovery, maybe even myocardial dysfunction? Has the adaptation gone too far?
Exactly. Is there a subset of patients, perhaps defined by duration or specific clinical features, where the ESS transitions from being purely adaptive or reflective of illness to being actively harmful at the tissue level? That's the critical research question. And if such a subgroup exists, how do we identify them? Simple serum T3 probably isn't enough.
So the question to mull over is, what kind of tools might we need in the future? Maybe specific biomarkers reflecting tissue-level thyroid hormone action, or perhaps different therapeutic approaches, not just blunt T4 or T3 replacement, but maybe more targeted interventions. Like, could TRH analogs or other upstream modulators potentially restore balance more safely in select cases of truly maladaptive prolonged ESS? Could we find a way to distinguish the adaptive response from a state of detrimental tissue hypothyroidism in chronic critical illness? And would targeted therapy in that specific window actually improve outcomes?
That's the frontier. Identifying that potential subgroup and finding the right safe intervention, that's where future research might lead.
A fascinating challenge, but for now, for today's practice.
Treat the patient, treat the underlying illness, and respect the ESS labs as a marker, not a target for replacement.
Couldn't have said it better myself. Stick to the evidence.
An excellent summary of a complex but vital topic. Thanks so much for this really insightful deep dive.
My pleasure. Always important to reinforce these principles.